Hey, good day and good evening, everyone. It's so great to see you all here. I'm happy that you decided to spend this evening with us. Before we will start, please let me know if you can hear me loud and clear, and if yes, then we will start. I will appreciate your feedback, so if anybody can let me know. Yes, all okay. Thank you for the feedback. I'm Sophie and I'm your host today. Welcome to IVF Webinars by Egg Donation Friends. Egg Donation Friends and IVF Webinars, this is the place where we link you patients, with the best fertility experts from all over the world. All our IVF webinars are recorded, and by this time we did 74 IVF webinars, and it's all available for you on our website, eggdonationfriends.com/IVF-webinars. IVF webinars are brought to you with help of our partners, and our partners are National Fertility Society, Fertility Clinics Abroad, and Donor Conception Network. And today, we are here with Dr. Natalia Szlarb, Medical Director at IVF Spain. So we say good evening to Alicante. Good evening, Dr. Natalia.
Good evening. How are you, everybody, tonight?
Yes, how are you? We are fine, thank you. And most of you probably know Dr. Natalia already, as she's here with us almost every month. And she has over 17 years of experience, and she's not afraid of difficult cases, and moreover, not afraid of difficult subjects. That's why we will talk about miscarriages and how to look for solution and where to find solutions. The presentation will take around 30 minutes, and next Q&A session will follow. So if you have any questions to Dr. Natalia, please do not wait with typing your questions in the chat section. You can start even now, and we will answer all your questions after the presentation. And not to waste any more time, we can start. So hopefully, Dr. Natalia, you are ready, and we can do IVF webinars together this evening. So fingers crossed, and let's do this.
Okay. Thank you very much, Sophia, for a great introduction. We are here to discuss today the reasons of miscarriages. So technically, when we see the miscarriage, it's a problem where the embryo that gets attached to the uterus lining, because of reasons that we're going to name, is getting detached, and we have to find out what are the most common reasons for this kind of detachment. In classical general gynecology, all miscarriages before 20 weeks of gestations are called early miscarriages. Everything else that happens later on are late miscarriages, and approach of them is, and workup of them is done differently. So we have to be aware that when we are born, we have a certain amount of eggs and certain quality of eggs in our ovaries. Majority of miscarriages that we experience are due to genetical abnormalities of embryos that are getting implanted. Majority of embryos which are genetically abnormal are embryos that do not get attached at all. Women, when they keep trying, they have usually negative pregnancy tests with genetically abnormal embryos. So these embryos who are genetically abnormal but are strong enough to get attached to the uterus, they're kind of cheating on the uterus lining. But there is a moment where there are signals between embryos and immune cells, where a genetically abnormal embryo is seen as a foreign body and is getting miscarried. So we have to be aware that we women planning our pregnancies later in life, we are the cause. Our advanced maternal age is the cause of our miscarriages. So this is something that we usually show, that the older we're getting, the lower number of genetically normal embryos we are generating. So the older we're getting, the more genetically abnormal embryos we have. And here we also see that the political revolution, the cultural changes, which allow women to study, be independent, use birth control pills to make it all happen in their lives. They postpone our maternity, and the number of children that we deliver when we see it through different years is lower and lower. So when patients are coming to IVF Spain, we always have to decide what are the chances to have you pregnant with your own eggs, or you are a candidate for an egg donation. What do we depend on? What do we decide on? We always have to evaluate your ovarian reserve, means 3A's: your age, your AMH, and your antral follicle count. We're going to discuss all the factors systematically. So we see that we women, we are designed to have children and generate healthy embryos until we are 35 years old. Later on, our fertility drops down dramatically. So at the age of 45, we do not generate genetically normal embryo. Generating genetically normal embryo is like winning $1 million in lotto. I've had in my entire career a patient not long ago. She was from London, UK, Chinese background, healthy lifestyle, who had genetically normal embryo at the age of 45 years old. But this embryo even get attached. She even was pregnant until 6 weeks. But then probably through the poor metabolical activity of this kind of embryos, majority of patients who are pregnant with their own eggs at the age of 45 experience miscarriages. So the older we're getting, the more genetically abnormal embryos we generate. A couple of years ago, we were focusing only on Down syndrome. Of course, the risk of a Down syndrome of patients that are older than 35 years, as you see, is 3.5 times greater than somebody who is 23 years old. But the genetical testing of embryos of blastocysts allows us to define through modern technology which one of these embryos that we are generating are healthy, which one of them have Down syndrome, which not. But not only Down syndrome. The older we're getting, the higher probability of a child with trisomy 18 or 13, Down, Edwards, and Patot syndrome. These are the most common ones. But new generation sequencing allows us to be very comprehensive, to examine all the chromosomes. So sometimes we see trisomy 1, 2, 3, something that we wouldn't be able to diagnose a couple of years ago. So when we decide to work with patient own eggs, age independently, the goal is to generate 5-6 day 5 embryos. So AMH, your anti-Miller hormone that we always checked on the day of a first appointment, and I'm famous for saying that one day, one patient, one first appointment has one problem solved. So we do not wait 3, 4, 5 weeks for AMH to go back. 2 hours. Okay, means in the morning you are in IVF Spain, we have your blood drawn, and in the afternoon we have a result and we can discuss it. Okay, and AMH tells me, what do I expect from you? How many eggs do I expect from you when we're going to do a cycle? So if you have AMH more than 2 nanogram per milliliter, which is UK 7, between 7 and 14, then I know that I expect from you about 20 eggs. Not everybody will develop to day 5 embryos, to the blastocyst stage. Only the strongest eggs are going to make this jump between day 3 and day 5. So we have to be aware that on day 3, embryos have just 8 cells. Day 5 embryos have 150, 200 cells. So only the strongest embryos are going to develop in 2 days into day 5 embryos. And then, depending on your age, when we take, and we're going to show it, 1 cell out of each embryo, we're going to show you how many healthy, how many genetically normal embryos you are going to generate, age dependent. So when somebody is 20 years old, somebody is in the age of egg donors, you can generate 80% of embryos which are healthy. We see sometimes cycles out of 5 blastocysts, we have 4, 5 euploid ones, 4 or 5 healthy ones. When we have somebody who is 35 years old, your euploid rate, number of healthy embryos, is 50%. So out of 6 day 5 embryos, only 3 are healthy. When we generate embryos from the same patient, but a couple of years later, when she's 40, your euploid rate is only 20%. So out of 6 embryos, I expect only 2 to be healthy, okay? So through that comprehensive embryo selection, this is how we do our best in IVF Spain to avoid miscarriages. Of course, you have to have doctors who know how to perform this kind of cycles, who have to be able to explain patients that embryos after genetical testing are getting frozen. And we have higher success rates in frozen cycles with genetically normal, healthy embryos than with fresh ones. And you have to have an amazing lab, amazing embryologist who are able to biopsy and have good freezing technology. So the post-thawing survival in IVF Spain is 99%. And on top of this, pregnancy rate per transfer with euploid embryos is 70%. Okay, so I wish everybody in Europe this kind of results. So Sophia will be so kind and she will show us how embryo develops between the moment we fertilize the egg, then how embryo reaches day 3 stage when we have just 8 cells. So probably I'm gonna, be quicker talking than the embryo dividing, and we already speed up a lot the process. So you see how blastomers are developing day by day, which we have it here on a quick motion. And then you're gonna see how from this couple of cells, we're gonna reach a blastocyst stage. So majority of our patients are asking, oh my God, Dr. Szlarb, when we biopsy our embryos, is it going to hurt them or not? So there was a Dutch paper published a couple of years ago when day 3 embryos were examined. You can imagine if this embryo has 8 cells and I take 1 out of it, I destroy 20% of its genetics. So the Dutch paper, Professor Masterbrook et al., were able to show that if we biopsy day 3 embryos, our implantation rate after biopsying day 3 embryos is lower than in fresh cycles. So medicine waited a couple of years for Spanish embryologists, UK embryologists, American and UK genetics to develop biopsy on day 5 embryos and blastocyst. So you can see here slowly, this is early blastocyst. And then this early blastocyst has 150, 200 cells, has here beautiful inner cell mass. So from this inner cell mass, I'm gonna have a parts of a baby, so I cannot touch it. And in this area around the embryo, we can take 3-4 cells and test it genetically to know if embryo is healthy or not, how many chromosomes this embryo is having, because embryos who have Too many or too little chromosomes are the most common cause of miscarriages. Now, Sophia, we would like to move on to the next slide. So you have to back up. Perfect. And now let's see what we have. Now we have to discuss how do we program cycles with PGS. How do we gynecologists allow ourselves to freeze embryos? How many eggs we're gonna generate? So we have to be aware that if I do PGS cycle with IVF PGS or ICSI PGS cycle with somebody who has AMH of more than 2 nanogram, which is 14 UK, more than 14 UK units, this person is going to generate me a lot of eggs. A lot, talking specifically scientifically, is more than 20. We have to be aware that somebody who's generating more than 20 eggs, each egg generates 300 units of estradiol. This person is going to have estradiol which is sky high. You can imagine that a couple of years ago, when we didn't have good freezing technology, we wanted to transfer everything fresh. We were afraid of this kind of high estradiols at the end of a cycle. And the person who changed a lot in reproductive medicine was Professor Shapiro from Las Vegas, who first published that his results in frozen cycles are higher than with fresh ones. So this approach we use in IVF Spain, where we first focus on generating as many eggs and embryos as possible in antagonist short protocols, we trigger with agonist. This will allow us never to hyperstimulate a patient, ever. We are hyperstimulation free clinic. Yeah. But this approach makes uterus lining in this cycle not to be receptive. This approach does not allow me to transfer right after an IVF cycle, but I don't care. I do not want to transfer in the first cycle. I want to biopsy the embryo. I want to see if the embryo is healthy or not, and then transfer. So the first step that patients are undergoing in IVF Spain is we focus on generating as many eggs and embryos. Patients are staying in IVF Spain for 1 week, where we see them every 2 days. We plan egg retrieval. We fertilize it with husband sperm. We develop embryos to day 5. Embryos are biopsied for genetical testing and frozen. Patients are flying back home, never hyperstimulated. And then when all the emotions and estrogens come down, in the next cycle, either natural or substitute, basically in substitute cycles, in artificial cycles, we have higher results than in natural ones. We transfer the embryo. So the second step of your treatment is you're gonna fly here for the frozen embryo transfer for 1 day only. If you are young, and in reproductive medicine, young is defined 35 or younger, because your euploidy rate is 50 or more than 50%, you can imagine that in one cycle, we can generate 6-8 day 5 embryos. 50% of them are genetically normal. So out of 6-8 good-looking ones, 3-4 are healthy. Frozen. The pregnancy rate after elective single embryo transfer with euploid embryos is 70%. After 3 transfers, cumulative pregnancy rate with euploid embryos is 90% in IVF Spain. So if we play it smart, in one cycle, we can do entire family planning. My ex-boss in the United States was always saying, yeah, in one cycle, we can generate an entire hockey team. So from the perspective of Hat Alicante, hockey team sounds promising, but this is something we can offer you when you're coming to us in the right time, that we can generate embryos for now to generate one child, and in 2-3 years time if you want to go back for the second one, we will have embryos generated from you out of one cycle. So in one cycle, we can do entire family planning. Now, embryo biopsy. I will ask Sophia to play the video for us, and then they do not hear me, Sophia. Okay, now I hope you can hear me. So what we see is, this is the blastocyst. This is day 5 embryo. You see that with the laser, the smart embryologist was able to make a small hole here. The embryo is hatching, is coming out, and is getting biopsied to see if it's healthy or not. And this kind of embryo, when the biopsy is done, is frozen. And only this technique allows us to differentiate if embryo has right number of chromosomes or not. If the embryo is good looking, can be AB quality, but has abnormal number of chromosomes, you will experience negative pregnancy test or miscarriage. Or if you go that far, that you are 10, 12 weeks pregnant, and we do the harmony test, and we discover that embryo is genetically abnormal, we let it to you, madam, decide if you want to have a termination or not. Okay, so I recommend to majority of our patients to perform embryo biopsy in order to avoid this kind of negative surprises or this kind of decisions that sometimes need to be made in the early pregnancy, which are not easy, neither for a patient nor for the doctor. So these are the results. These are the embryos which have normal euploid number of chromosomes. And this is embryo with too many chromosomes in the position, I think, I don't see it well without glasses, but it's probably 21. So it's trisomy 21, which will result in a Down syndrome if we transfer this kind of embryo. In Spain, only genetically normal embryo can be transferred. Even if you sign that you want a genetically abnormal embryo to be transferred, it's against the law. There's a lot of patients asking me if we transfer mosaic embryos. The answer is yes. We do transfer mosaic embryos. Mosaic embryos are embryos, as you can imagine, which when we look at this beautiful blastocyst, you can imagine that this blastocyst can be a mixture of different cell lines, okay? And when we biopsy it, we might biopsy one line and the embryologist can touch the other line, and then this embryo is defined as mosaic. Majority of mosaic embryos are getting repaired during the pregnancy, but you can imagine if we have this kind of embryos, we trust them, we give them the chance to get implanted, but we control them. We have to be aware that the miscarriage rate with mosaic embryos is higher than with genetically normal embryos. And all the patients that are getting transferred mosaic embryos at IVF Spain sign certain specially prepared consent, which says that at 10, 12 weeks of pregnancy, you need to do amniocentesis, okay? With the needle, the amniocentesis needs to be done. So we check the fluid, the amniotic fluid of the baby to see if baby is healthy or not. This is how medicine develops standard for double checking mosaic embryos. So when we see the pregnancy rates of ladies which are older than 35 and they do not do genetical testing of their embryos, the pregnancy rates are only 18%. Okay, are due to this that majority of our embryos are genetically abnormal. And we have to be aware. When I have girls at the age of 35 years old where they undergo genetical testing of their embryos, which is very comprehensive study that allows us to see if embryo has a proper number of chromosomes or not. Your cumulative pregnancy rate after 3 transfers with this kind of embryos is 90%. Okay? We have to be clear that if we see that we are not able to generate genetically normal embryo, your pregnancy rate is 0 and you do not appear in our statistics. And this is the moment where I had a phone call yesterday, 38 years old lady from Bulgaria. And she says to me, Dr. Szlarb, but 2 weeks ago we had 2 embryos biopsied. And I say, madam, but all of them are genetically abnormal. Means that euploidy rate when somebody's 38 is 30%. But when we have, so few embryos, or sometimes we see that X quality due to your age is poor, we know that this statistic doesn't apply to you. And this patient will not have a transfer. This patient will be offered an option of something called embryo banking, where we will perform 2-3 cycles to generate 6 embryos, to apply 30% euploidy rate out of these embryos, or if embryos have bad quality, C quality, or even lower, this person will be offered an egg donation. Yeah, this person will not have this good-looking embryos but genetically abnormal transferred, because these embryos are going to cause negative pregnancy tests, which are going to make our statistic bad. These embryos can cause miscarriage. These embryos can cause us a lawsuit, because when you transfer genetically abnormal embryos and somebody is 10, 12 weeks pregnant, harmony test comes out positive and you need to have a termination, your doctor can be in trouble. Okay? Okay, embryo banking. This is for patients who generate good-looking embryos, good quality, AB, but have low AMH. So if somebody generates us 1-2 healthy blastocysts, we want to have more of them. We want to bank them. We repeat cycles every 2-3 months to generate more blastocysts, to find 50, 30, 20% good ones, healthy ones, after genetical testing. So egg donation. Egg donation, this is something that we have to discuss when we see that there is no genetically normal, healthy embryos left. According to the Spanish law, egg donation is performed since more than 30 years. It's anonymous. Means I can only tell you age and blood type of a donor when you are pregnant. According to the Spanish law, we have to generate a child that will explain the combination of you and your husband, and then your egg donor and your husband. So I always say to patients that I have to find you a twin sister, somebody who looks like you, has the same color of hair, color of skin. So when we meet one day and your child will run around us, everybody has to think that you are a genetical mom. In IVF Spain, we have more than 500 donors available for you. Where from? We always speak to students that they have to have children before you are 35 years old. Trust me, nobody takes me seriously, but it's not the first time. But in my age, I'm slowly a mother figure for them. So I allow myself to teach them about birth control pills, condoms, safe sex, something that my mom, who was also a gynecologist, used to do with students in Germany. And then we teach them that your fertility is stable before 35. And then you have to freeze your eggs if you're not pregnant before 35. So there's a lot of young people, young students coming to IVF Spain. They perform social freezing. They freeze eggs for themselves. And we check their AMH. We have to make sure that they are healthy. We check them for infectious diseases. We check them for genetical diseases, 29 most common genetical diseases. If we have patients with certain ethnical background, like Greek, Turkish, or African American, or African, let me put it this way, We know that there are some diseases specific for these populations. I had today somebody with spherocytosis, a couple of days ago, sickle cell disease. So we have tests that allow to match a donor to your husband who is not a carrier of the same disease that your husband is. The donor undergoes mental health screening. And there's no mercy. We have to understand that in gynecology, in general medicine, we can confirm or exclude some things through the blood work. But mental health, no. It has to be a specialist who comes to the clinic, has a serious conversation with donors, and makes a test, mental health test. And we know that if somebody is predicted to schizophrenia, depression, personality issues, drugs, we check drugs. We check drugs in blood of donors regularly. And if somebody is taking drugs, you cannot be our donor. If you're delusional, you cannot be our donor. Okay, so this is how systematically we work with our donors. In the second step of donor choosing process, you receive from us paperwork where you describe yourselves. How tall are you? Color of hair, color of skin. We ask you what is important for you, which characteristic of yours your donor shall have. We see your pictures. We put your pictures to the computer. Computer shows me shape of your face, eye, nose, mouth, matches to different donors. And then 20 best donors are coming out. The donors are in 5 groups. Phenotype 1 are donors with blue eyes, phenotype 2 green, phenotype 3 brown, phenotype 4 girls from Asia, phenotype 5 girls from Africa. So if we want to do, we doctors, we want to perform our job correctly, we have to have donors out of 5 phenotypes for everybody. Okay? And then computer, without any feelings, has facial matching system and shows me 20 best donors. And then once a week, all the doctors sit down together. I show my colleagues my cases, they show me their cases, and then we eventually decide who, in our opinion, is the best donor for you. So these are the steps of donor choosing process. Before we put any embryo back to you, we have to do something called test cycle. Means with artificial hormones, we have to mimic your natural cycle. A couple of years ago, when me and Dr. Rochel, we were still young and pretty, we used to try to synchronize natural cycle of a patient with IVF cycle of the donor. We grew out of this kind of dreams. It's not doable. The only way to synchronize 2 ladies that are menstruating in different parts of the world is to synchronize an IVF cycle of a donor with a substitute artificial cycle of a patient. So substitute cycle means that with artificial hormones, we mimic your natural cycle. We give you 15 days estrogens. Day 10 of a cycle, we have to scan you to see how thick the lining is. And then we know if this dose of hormones is well adjusted to your body or not. And I'm like a broken record. I just want your lining to be between 7-12 millimeters. Then I know that the test dose that we are giving you is correct. And then if I know it, we put you a couple of days on birth control pills. We put you on birth control pills together with your donor. This is how we synchronize you. You ladies stop it together and you have a withdrawal bleeding together. You have a period together. And then a patient, a recipient, takes oral estrogens. Day 10 of a cycle needs a scan. And the donor does an IVF cycle. She puts injections to let her eggs grow. And then patients are flying to us basically for 3-4 days for transfer only, where we fertilize fresh eggs of your donor with, in majority cases, when sperm quality allows us, with frozen sperm of your husband. If there are sperm quality issues, we want to fertilize with fresh sperm, then your stay is longer. If the sperm analysis needs improvement. We want to fertilize with fresh sperm. Your stay in Spain for the transfer is about 7-8 days. When we can allow ourselves for fertilization with the frozen sperm, then you're flying just for the transfer for 2-3 days. The pregnancy rates in egg donation are amazing. Through egg donation, if your womb is anatomically okay, there are no fibroids, no polyps that can stop implantation, we bring you to pregnancy rates of somebody who is 20, 30 years old. After one transfer, 70% of patient pregnant, after two, 90, after three, 97%. There are, some complicated cases that need a very special immunological workup. We have to match the donor to you immunologically. So the male infertility increased. So according to World Health Organization criteria, 40% of infertility cases are due to the male factor. It impacts embryos quality, but as I say, through genetical selection of them, we are able to select them in such a sensitive way that if there's a male factor, maybe you generate less healthy embryos, especially when men have karyotype abnormalities or pathological fish sperm test. But still, I have seen in my career men with pathological sperm fish test with genetically normal healthy embryos. Each patient on the day of the first appointment gets extensive sperm analysis workup. So the first part is World Health Organization criteria, basic volume, concentration, motility, morphology, and then DNA fragmentation. If there are alterations in DNA fragmentation or the 33rd, the protein balance in the head of the sperm is not the way it should be, we perform testicular aspiration biopsy on the day of an egg retrieval, so it's not a problem at all. So we talk a lot about embryos quality that gets down due to this, that women are postponing their maternity, that we study, that we develop our careers, and basically at the age of 40, when we have a man that we believe is going to stay with us till the end of their life, where we have a beautiful house, car, and garden, we want to have a child. 20% of our eggs at this time are good. So for young, smart, ambitious girls, I can recommend only social freezing. Freeze your eggs before you are 35 years old. It's the best investment. It's the best Christmas gift you can, or Thanksgiving gift you can allow yourself. If we know that we generated genetically normal embryos, where 70% is the pregnancy rate with transfer of genetically normal embryo, before we transfer them to you, in majority of cases, we perform uterus lining biopsy. Some of my colleagues say that this kind of cycles are reflection of Dr. Szlarb's obsessive-compulsive personality disorder. Means it has to be checked 3 times that everything is okay on time. Then you are allowed to have a transfer. And it has a reason, because 70% of all the patients have implantation window with 5.5 days progesterone intake. There are 30% of patients that need 6-7 days progesterone to open implantation window. And if I have embryos of an egg donor, I can repeat this kind of cycles easily. But if I have patient own eggs and there is one only embryo that we generated which is genetically normal at the age of 40, is probably one of the genetically normal embryos that we can generate. So before I transfer this embryo, I'm not going to wait for recurrent implantation failure. I'm not going to wait for 3 miscarriages because they're never going to occur. So in selected cases, right before the first transfer, we perform uterus lining biopsy to see not the level of progesterone in your blood, but how many days before embryo transfer you should take it. So immunological issues we are able to solve through the uterus lining biopsy, and depending on the results, there are certain protocols applied. There will be a webinar with one of our immunologists, and she'll discuss this topic extensively. I would like to show you 2 practical cases, and this will be the end of my presentation. So you understand how important the genetical testing and receptivity is. So a case study that changed my life completely was a couple of years ago, a case from Berlin, from the city where I was trained. 42 years old patient. She had very low AMH when she came to us, 2 pregnancies, 2 miscarriages in her history. She had 2 IUIs in Berlin, 3 IVF cycles, which resulted in these 2 miscarriages. We evaluated her ovarian reserve, HAMH, antral follicle count, low AMH, over 40, low euploidy rate. We decided to perform an egg donation. It was still the time where in IVF Spain, majority of egg donation cycles we were performing in the fresh cycles. We were guaranteeing 5 blastocysts. 1 was transferred, the rest was frozen. So what happened was the first transfer resulted in the positive test, but the lining was poor, and at the end it was a miscarriage. The embryo couldn't attach, didn't have enough tissue to attach. In the second single embryo transfer, pregnancy test was negative. In the third double embryo transfer, patient had a positive pregnancy test, but she miscarried. And what happened was the material which she miscarried underwent genetical testing. And I'll never forget this result. When I received it, I saw that one of the embryos was a healthy female embryo and the other one was trisomy 13. So it was the first time where I had to understand that egg donors are young, but still nobody's perfect. Nobody generates 100% genetically normal embryos. I was a little bit nervous when I saw this case because the patients were able to prove me that in IVF Spain, due to my job, genetically abnormal embryos were transferred and they were cause of a miscarriage. So the patient came back and we agreed on a second egg donation cycle and testing of embryos of a second donor genetically. It's a mistake here. We do not transfer in IVF Spain single euploid embryo. It's frozen. Frozen cycle, 1 genetically normal embryo transferred, and it resulted in a healthy delivery of a healthy, amazing boy. The rest of the embryos I still have frozen for this patient. I do not think that because of personal reasons that will be transferred. But this was the moment where a majority of second egg donation cycles started undergoing genetical testing. We observed the time to pregnancy after this kind of approach is shorter than in fresh cycles. We understand that nobody's perfect, and then we have to be aware that there's certain data published showing that euploidy rate, number of healthy embryos, is between 60 and 80%, even by egg donors. So when you are older than 35 years old, definitely your embryos should be tested genetically for euploidy. So these are the most three common abnormalities that our eggs experience due to our advanced age. Too many chromosomes in position 21, which results in Down syndrome, trisomy 18, Edwards syndrome, trisomy 13, Patau syndrome. So with Down syndrome, it's a huge psychological disability, low IQ. There are some heart abnormalities of these individuals. Some of them will leave their lives, but they are depending on their family. Edwards and Patau syndrome. Being honest with you, I saw a couple of these kind of cases in pathology. I've never seen somebody being alive with this kind of syndromes. Some of them are caused, are reflected through big anatomical changes, head abnormalities, heart, lungs abnormalities. So majority of this kind of embryos do not survive. They get miscarried. And this is the most common reason why the embryos are getting miscarried. The second case and the last that I will present is for patient own eggs and the receptivity. So here, summarizing study 2012, we see that about 60,000 embryos were genetically tested from all over the world. And we see out of 710 embryos, egg donor has 60% good ones. When you are 35, 40% of your embryos are good. The older we are getting, the lower number of healthy embryos we are generating. So basically at the age of 44, egg donation is the only solution that we have for you. The second case that I would like to share with you was a beautiful Ukrainian girl, blonde, blue eyes. I always told her that she looks like Maria Sharapova, but with the taller version. So she had this, beautiful body of a model, and she was 27 years old when I met her. Her AMH was 3.5. She had 20 antral follicles. So basically, with these numbers, she could be an egg donor. She had never had a positive pregnancy test in her history. She had 2 previous IVF cycles in different centers with day 3 embryos. She came to me and she was desperate. She wanted to have a baby now. Even if I would have said egg donation, she would have agreed. Okay, so when somebody's so desperate, you have to use your common sense and say, Madam, you have an ovarian reserve of a donor, egg donor. We cannot transfer fresh because you're going to generate me a lot of eggs and embryos. And we really can generate a whole hockey team out of these numbers, because all the predictive factors of ovarian reserve are on your side. So we were able to generate 25 mature eggs. It was more than 30 eggs overall. We generated 8 day 5 embryos. After genetical testing, 6 of them came out genetically normal. And then what happened was I transferred one of those embryos, And after single embryo transfer, even though the embryo was healthy, the pregnancy test was negative. And how in the world you gonna explain to somebody who's 27 years old, who is young, that sometimes genetically normal embryos do not implant? So what you do is you do a receptivity test. And what you see is with an average receptivity, 5.5 days, she's pre-receptive. Means that embryo that you have transferred before was in the womb, transferred not on time. So what you do is you do a confirmatory biopsy. There is no trust anymore. No trust. We have to verify where your implantation window is. So you can imagine that it took us two biopsies, two confirmatory biopsies, to confirm that she's receptive with 7 days progesterone. And then, when she's receptive on 7 days progesterone, it took us a couple of cycles to get into this conclusion. She's getting nervous and even more impatient that you had her on the day of the first appointment. So she wants double embryo transfer. So yeah, sometimes common sense does not allow you to avoid this kind of movements. So we performed double embryo transfer with 7 days receptivity. Means I gave her 7 days progesterone, and after this 7 days of progesterone, her implantation window was open, and we put 2 day 5 embryos, and she delivered one of the most beautiful twins I've ever seen in my life. Okay, so we generated an entire hockey team. If she wants to go back in 2-3 years for more children, we still have embryos from her frozen at the age when she was 27 and had an amazing ovarian reserve. Okay, so here is to show you how genetical testing is important to avoid miscarriages, how receptivity verifying is important to avoid negative results, negative pregnancy test, patient journey. Drop us an email to patient or contacts at ivf-Spain.com, or contact Egg Donation Friends. If you have any personal questions, drop us an email. I'll be more than happy to have a free Skype with you. We are regularly once a month. We are in UK. Next year, I already planned 3 flights to UK, 3 flights to Ireland. So we'll be seeing patients in UK and in Ireland. I already planned 3 flights to the Netherlands and Belgium, and regular flights to Germany. So our marketing department will be working around it. So if you want to see us in person in your home countries, we will be there soon for you. So Dr. Spurwa is an owner of a clinic. I'm a medical director. I joined the team 8 years ago, where thanks to American medicine and Spanish sun, I can share my medicine with you. Dr. Rogel is responsible for our donors. Dr. Herrera, Dr. Alvarez are devoted doctors to the patients. Dr. Pak takes care of German patients. Professionally, we have an amazing time together. This is our lab, senior embryologists. These 4 ladies are focusing only on embryo biopsies. They do not do any simple stuff with us. Guys here, younger guys, they perform embryo transfer with us. Javi, not long ago did one of the most challenging mappings, testicular mappings in my life. So the young guys are getting skilled to be as good as the older guys. So we'll be all more than happy to help you.
Yes, and thank you, Dr. Natalia, for your presentation. We will now take a look on the questions which we have already asked, and we will start with the first one just in a second. Yes. Yes. And here's the question. Hi, I am a 39-year-old woman who has just experienced my fourth miscarriage in 11 years. I suffer with unexplained subfertility and unexplained recurrent miscarriage. Each pregnancy ends at 7.5 weeks. I have had NK cells testing, been tested for various autoimmune issues and various clothing disorders such as lupus. Hysteroscopy have returned no concerning results. I have borderline PCOS, but this has never interfered with my cycles. Can you suggest any further issue that I could be tested for, which may be causing the miscarriages?
Okay, we have to differentiate general immunology, which is called rheumatology, from immunology of implantation. Okay, so in this kind of cases, we always write letters to rheumatologists that you are not in an acute phase of your autoimmune disease, because this can cause miscarriage. Everything else can be influenced by prednisone. Yeah. Um, you can imagine that I have myself autoimmune disease, and when I came to Spain, I was on 10 milligrams of prednisolone for 5 years. You don't like it. You have all the side effects. You can develop Cushing syndrome. Uh, Not good, not good. But sometimes, rheumatology goes first. And when your rheumatologist says that she's stable, that she doesn't take medication like methotrexate, or there are new modern medication for autoimmune diseases that are not allowed in the pregnancy, uh, and rheumatologist puts you on prednisone. This way, we have lupus and majority of autoimmune diseases under full control. Now, you are 39 years old, madam. Please review the chart. That, because of the lack of a time, I flew by very quickly. So, 60,000 embryos were examined in 2012. Your euploidy rate is 30%. So, before you transfer anything to yourself, again, please perform an IVF cycle with PGS. Please do it in the experienced lab where doctors will not be afraid to hyperstimulate you. I want to know as many eggs out of you as possible, because when you are 41, 42, your euploidy rate is lower than now. So what you freeze now, genetically normal, healthy, is like gold. It's for you forever. And then when I know that you do not only have good looking embryos, good morphology embryos, but they're also healthy, we can always negotiate when we transfer them to you, that your full immunology through rheumatology is under control. And in this kind of cases, when you experience miscarriages, when we know that we transfer genetically normal embryo, I'll have to do the uterus lining biopsy, probably to see your NK cells, Th1, Th2 ratio balance, to probably apply the immunological protocol that is allowed in the pregnancy. For now.
Perfect. Thank you for the question and for the answer as well, of course. And now we will take a look at the question, which has two parts, but they are totally in the same topic. So, can AMH differ at different months each time the test is taken? I spoke to a multiple times egg donor whose IPs had a child with her ex at her worst AMH out of all the other 5 times. What is your opinion? And is there an ideal AMH that you would like to see?
You know what? A couple of days ago, I had an amazing same-sex couple that came to us to treatment in Spain. What you can do is you can do something called ROPA technique. Means ROPA stands for recipiente de los ovocitos de la pareja. Means that you can receive the eggs of your partner. So when you have same-sex couples, same-sex girls in a relationship, one of them is generating eggs. We do an IVF cycle. We fertilize it with the sperm of a donor, and then we can transfer this embryo to her, wife. and 2 girls, 27 years old, beautiful, nice, smart, well educated. One of them, AMH 5, 25 antral follicles. I was like, oh my God, lady, you can be an egg donor. Her wife, AMH 0.6. And then AMH tells us, how many eggs do I expect from you when I do a cycle? There's no ideal AMH. You have to know how to work with certain AMH, and you have to know when you do a cycle, how many eggs do you expect out of this treatment? So when I have a lady who has AMH 5 point something, I expect more than 30 eggs in a cycle. So I have to, work hard to do an egg retrieval well, so she's not gonna, bleed, that she's gonna be well, okay? When somebody has AMH 0.6 and is 27 years old, if I have 4 or 5 eggs out of this kind of treatment, I'll be over the moon. So then what you say, madam, you have to do embryo banking. You have to generate 2-3 embryos now, 2-3 embryos in 2-3 months. So when you work hard, your age still can move the mountains. Through your age, we can generate 6 embryos, but it has to be a hard work. Yeah, I have to see you, madam, every 2-3 months. Okay. So there is no ideal AMH. I know with AMH more than 2 in one cycle, when somebody is 35 years old, I can do entire family planning. When somebody has AMH between 1 and 2, in mild cycle stimulation, I was this year on ESHRE, European Society of Human Reproduction. We do not recommend in Europe more than 300 units of hormones of recombined FSH. So in IVF Spain, the dose is 225, 250. So when I apply this kind of protocols and antagonist short, between AMH between 1 and 2, I expect 10-15 eggs. When AMH is under 1, it's age dependent, how many embryos and how many eggs you're going to generate, and how many euploid ones you're going to have.
And the first part was, can it differ in different months each time the test is taken?
No. AMH tells me about your ovarian reserve, madam, overall. If you open up the general gynecology book, you're gonna see, it's a typical question that you ask students when they, have to become gynecologists. What can negatively influence your AMH? The answer is treatment of autoimmune diseases. I had a patient with rheumatoid arthritis on methotrexate. You have to recover after methotrexate 6 months so I can treat you. When I first saw her AMH was 0.7. She was crying. When I let her recover, we both stayed cool. Yeah, I opened up secretly my gynecology old book, and I'm like, this cannot be. We waited 6 months, and her AMH recovered. She had AMH more than 2. This can only happen to you, madam, when you are young. Okay, when you are older than 35, your AMH can only go down. It doesn't differ in different parts of the cycle. What differs is your FSH. FSH under 3 of a cycle is cycle dependent. Tells me how many eggs I'm gonna win in this cycle or not. So FSH is cycle dependent. AMH tells me about your ovarian reserve overall. Cycle independent.
Yes, perfect. Thank you for 2 questions and your answers, Dr. Natalia. And we will take a look at the next question, which is also in 2 parts. So, when the PGS needs to be done? At blaster day 5 only. If the blaster is formed at day 6, can PGS be done? And if the day 6 blaster was already frozen, can PGS be done later?
Okay, so you can imagine that some embryos are like children. They're a little bit slower than everybody else. So there are some good embryos that reach the blastocyst stage not after 5 days, but after 6 days. And this day 6 embryos are equally good as day 5 embryos. Okay, so the answer is yes. The PGS testing can be done on day 6 embryos. In some cases, we even perform day 7 testing, but this kind of embryos are very poor. Okay, so we know that majority of day 7 embryos will be genetically abnormal. Now, this is the first part of the question. The second part of the question, if the embryo is frozen, can PGS testing be done? The answer is we have a very negative experience with this. Means, now thaw the embryo, biopsy, and then thaw it again. In majority of my cases, it didn't work out properly. So, transfer this what you have, do the harmony test if you're pregnant. If the results are not on your side, you have to decide something. And if the next cycle needs to be done, perform genetical testing on new generated embryos.
Yes, and huge thank you for your expertise on this one, Dr. Natalia. And the next question on the list is this one. Age-dependent success rate of IVF pregnancy is based on the donor egg's age, correct?
Yes, ma'am. So I always explain to patients, if I transfer egg donor embryos to somebody who is 30 years old and she's in premature ovarian failure, she is in early menopause, or somebody who's 40 years old and has poor egg quality, or somebody who's 50 years old and she's in her natural menopause, I still can we can still make your lining grow like we want to. Okay? And your pregnancy rate are 70% with blastocyst per transfer if this is egg donor age independent. So you have pregnancy rate of somebody who's 20 years old. Amazing, huh?
Yes, indeed. All right. We have now interesting question, I think, a little different perspective. Does the men's age increase the risk of miscarriage?
Carol, don't blame yourself. Not at all. As long as you have good sperm analysis, you do not, increase risk of miscarriage. I always, you still remember some cases in your life till the end of your life. I had patients who came to us and we did an egg donation cycle. And in the first egg donation cycle, all the embryos turned out to be genetically abnormal. All. I had to call them. So they went to the clinic in UK, and the man got extensive workup. And then what we saw was that karyotype of this man was okay, but in sperm fish result, it's a genetical sperm testing result, there were some abnormalities. And then, we want to have time to your pregnancy as short as possible. So in second egg donation cycle, seeing this result, I recommended them sperm donation. I did. And the patient was stubborn. And he said to me, no, Natalia, I want to, try a second donor with my own sperm, even though I have abnormal fish genetical sperm result. I said, sir, fine, if you have so much time and if you are ready, that we can experience again such a negative result, I'll support you. I'll do it for you. Because in IVF Spain, we offer you 5 blastocysts, 1 euploid one. So if you cannot fulfill this guarantee, we have to stimulate a new donor for you without any extra costs. Yeah. So we stimulated a new donor, another good donor. And this man, with these genetical abnormalities in fish sperm test, was able to generate me 3 euploid embryos, 3 healthy embryos. Okay? And trust me, I've seen 2 children out of this cycle. Okay? So, men's age, when your sperm analysis is good, does not increase the risk of miscarriage. The donor egg can erase your age. And genetical testing of your embryos, even though man has genetic abnormalities, if the sperm and an egg are able to correct their genetic abnormalities, Yeah, I've seen in my life healthy embryos out of this kind of stories coming out and healthy children. Yeah, but you have to be in a good genetical lab. The guys that perform genetical testing on embryos have to be skilled very well, and you just have to, psychologically, sometimes it's not easy for you to hear from a professional like me, sir, in the first cycle we have no embryos. Okay, so sometimes if you have your own pathology that you are aware of, you have to wait for genetically normal embryos to happen in your life. Yeah, that is involved with time and budget quite often.
Great, thank you for the explanation. And Dr. Natalia, can we come back to the previous one, just with a short confirmation? So do you mean it is not feasible to do PGS after the blaster is
No,
frozen? The PGS
no.
will be done before blaster is frozen.
Yes, I wouldn't recommend, from my experience, anybody to thaw, biopsy embryo, and then freeze and thaw it again. Okay, the best results in IVF Spain we have through genetical testing of fresh embryos, which are getting then frozen, and they are thawed only once in their lifetime before transfer, 2-3 hours before the transfer.
Yes, and thank you for making this clear. And the next question will be this one: do mosaic embryos happen very often?
You know what? I was waiting for this paper to be published quite, a couple of years. And in 2017, from Oxford, we found out that 20-30% of embryos that we generate could be mosaic. Yeah, but I'll tell you one thing. This number in IVF Spain, I cannot confirm. We have less mosaic embryos in IVF Spain. So I would say that mosaicism, but in IVF Spain we are spoiled because majority of cycles that we do are egg donation. So these are amazing cycles. So the mosaicism, when we see embryos overall of egg donation and patient owned eggs are between 10 and 20%.
Perfect, thank you for the question and your answer to this one. And we will now jump to the next one. I am 42 and I was advised to go for donor eggs. I've heard that miscarriage rates are 50% if I tried with own eggs. It is also true that live birth rates for IVF with your own eggs are only 10 to 15% at such age.
Madam Carol, the pregnancy rates with 42 without genetical testing is even less than 10-15%. So I have seen a couple of cases in my life where somebody at the age of 42 had genetically normal embryos. So you need, Carol, a good evaluation. You need to see pragmatically your ovarian reserve. Okay? And I'm like a broken record. Age, AMH, antral follicle count. Age, my wish list. Patient under 40 years old. AMH between 1 and 2. Antral follicle count, transvaginal scan, more than 6 follicles. I can only give you a green light with your own eggs when 2 out of these 3 criteria are fulfilled. So you have to do homework yourself. How many of those criteria have you fulfilled? If you are fulfilling less than 2 or none, go the egg donation route.
And thank you for your sharp explanation to this question. And of course, we have the next one. I discovered that this is also about PGS, but I have 4 day 5 embryos from a donor. Can I test PGS before the transfer? First transfer was without implantation.
Nicole, it's, I was also waiting a couple of years for this paper to happen. When euploidy rate in egg donation embryos was, compared between different centers. So euploidy rate should be between 60-80% per center. If embryos are frozen, do not test them genetically now. Do not, because there with a high probability are healthy. What you need to do now, before you transfer again, you have to confirm your receptivity. You have to do the uterus lining biopsy to see if the reason that the embryo did not implant the first time was that embryo was weak and didn't implant, or you have a unique immunology or unique receptivity that needs 6-7 days progesterone to open implantation window. Okay, so I will highly recommend you endometrium receptivity testing.
Great. Thank you for the question and, of course, for your answer. The next one, and we have two more to go. I'm 45. I have irregular cycle. If I go for egg donation, do you prefer to transfer frozen embryo or fresh one after using medication?
Your cycles, if they are regular or irregular, I don't care. Majority of cycles in egg donation for recipients are in substitute artificial cycles. So, we work with patients this way that we set up the date when you are available to come for the transfer, and then you're just flying for 1 day for frozen embryo transfer in substitute cycles. For patients who have regular cycles, majority of them, we downregulate them. We give them medication that stops production of female hormones in their body. We put them artificially into a menopause for 3 months. So this way we can synchronize them with the donor, better. So your irregular cycles, if you are perimenopausal, do not matter at all. With substitute hormones, with 15 days estrogens, 5.5 days progesterone, we can move your cycles like we want to. We can make you regular.
Yes, and great. Thank you. Again, the next one on the list is this one. Do you ever do cytoplasm replacement transfer with donor and mother's eggs? Is this the same as mitochondrial replacement transfer?
Angela, this kind of procedures in Spain are forbidden. According to our law, the embryo that we transfer have to be genetically from the same person. Okay, it's no go that I transfer one embryo from you and one embryo from the donor. It's completely illegal, and it's completely illegal to replace a cytoplasm or mitochondria of an egg donor through your own ones. Yeah, it's this kind of practice is not allowed in Spain. In Spain, reproductive medicine allows you for almost anything you can dream about. Allows you for genetical testing of embryos, allows you for egg donation, does not allow you for this kind of procedure that you mentioned, that the nucleus is from one person in a cell and the cytoplasm is for the other. It's absolutely no go. Transferring genetically embryos different from two different donors does not allow you for sex selection, does not allow you for surrogacy. Yeah, and that's about it. Everything else you can do in Spain.
Yes, and thank you for the answer and explaining this to us as well. I have, of course, a shout out. Thank you very much, Dr. Natalia, for your answer and your presentation, which was detailed and very informative. So thank you again. Thanks for the information, Dr. Natalia, one more time. Okay. And thank you, everybody, for being with us. As I mentioned, thank you also for your time, and to you, Dr. Natalia, for your knowledge and for sharing this knowledge with us. We have one more IVF webinars with IVF Spain in 2019, and it will be in December, and we will meet here again. So yeah, stay tuned, and hopefully we will see each other here again. Dr. Natalia, if you want to add anything, please, you can take a second to do that now.
Okay, thank you very much, everybody, for listening, choosing us and not the soccer game. Sophia, as always, thank you very much for a cold blood It's the second webinar that we have technical issues to solve. You're doing an amazing job, and even though we had some technical issues at the beginning, I'm glad that we were able to bring this webinar to a happy end. As I say, please contact us with any personal issues at our webpage or through Egg Donation Friends. Thank you so much, and have a good night. For people listening me from the other side of the world, Canadians are after Thanksgiving. In the United States, we will be having Thanksgiving very soon. So enjoy your Thanksgiving turkey, and hope to hear everybody before Christmas.
Yes, and thank you. A huge thank you to you as well. I'm also glad that we managed to do this webinar. And of course,
Well done.
I encourage you to follow us on our social media as Egg Donation Friends, where you can find all our IVF webinars and all the materials which we share with you. And of course, you can as well follow IVF Spain. They have great content there as well. So feel free to join us, and this is always a pleasure. Greetings and bye-bye to Alicante, Dr. Natalia. Thank you. Have a great night or day wherever you are.
Bye.